Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network at the UNC Lineberger Comprehensive Cancer Center. Thank you so much for being with us today, April 24th, 2019, for our Medical and Surgical Oncology Live Lecture. Just a few preliminaries and then we'll meet our guest and get started. If you have any technical issues going on at all, please call our staff at 919-445-1000. They are standing by to assist. You can also email us at unccn@unc.edu. Lots of information about us on the web at unccn.org, lots of other places as well, but I would start with the web. Past lectures, future lectures, information about the program, so we hope you'll visit us there. Let's see, we have a new program which I've mentioned in our newsletter and elsewhere. This is our promoter program. Thank you so much to Lori Bryn and to Eden Somerville Gifford, who are our new promoters. Again, a promoter, if you missed this in the past, is somebody who helps us out by simply forwarding on information about the lectures and, if possible, posting flyers about the lectures. We're so appreciative to all of our coordinators, our promoters, and just let us know if you have any questions about joining us in that effort. Poll Everywhere. We always use Poll Everywhere. Allows you to participate and have a part in this lecture and share your questions and answers with our guest. Today you can join either via a phone using the texting capabilities in the to field, put in 22333, and in the message field, UNCCN, you'll go ahead and submit that. You'll get a little message back that says join. Then you can put in the letters that correspond to our questions, and you can also text in questions at the very end. An equally simple or even simpler way to do this is just to go to any browser on a phone, on a computer, on a tablet, go pollev.com, pollev.com/UNCCN. You'll see the questions as they appear in the lecture. You can answer those and then you ask your own questions at the end. All right, the question that we'll open up with, which of the following is not a symptom of bladder cancer? If you believe that's blood in urine, you would put A, painful urination, B, pelvic pain, C, or new onset or change in pattern of headaches, D. So go ahead and you can do that now if you like. And without further ado, I want to introduce our guest today, Dr. Pruthi. Thank you so much for being here.
Yeah, thank you.
All right, let's see a little bit about you. You're the chief professor and chair of the Department of Urology and professor of surgery urology at the University of North Carolina at Chapel Hill.
Yeah.
Great. And you serve as disease group leader for the genitourinary oncology program at the NIH-sponsored Lineberger Comprehensive Cancer Center here at UNC. And clinical and research interests are in urologic oncology, including bladder, kidney, and prostate cancer. Did we get that right so far?
You did.
Good, good. What's one other thing that we should know about you?
One other thing to know about me, well, I'm a father of three.
Great.
With our youngest graduating high school this year.
Oh,
and he'll be attending the University of North Carolina.
Good choice.
So I'll be an empty nester with my wife, and we're looking forward to that.
All right. Well, good for you. Congratulations.
Yeah, thank you.
Well, let's take a look at that. We do have disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development, UNC CPD. Dr. Thomas Shea consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. Dr. James Coghill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. The speaker, Raj Pruthi, MD, has no conflict of interest relevant to this presentation. All right. And now's an opportunity if you, looks like we haven't gotten answers to that poll yet, but which of the following is not a symptom of bladder cancer? A, blood in the urine, B, painful urination, C, pelvic pain, or D, headaches that gradually become more frequent and more severe. How are they doing?
They got it.
They got it. Good.
Yeah.
We try to throw you kind of a softball at the
beginning. Yeah.
All right. Well, without further ado, you can just go ahead and hit that right button and improving outcomes in radical cystectomy with Dr. Pruthi.
So I'm going to take you through a little bit of a whirlwind on the surgical treatment of invasive bladder cancer and just a very little bit of background information. Then I'm going to jump into how do we optimize the care of patients undergoing cystectomy. Bladder cancer is the 4th most common cancer in men and 11th most common in women, with about 80,000 new cases a year. As you can see here, 17,000 deaths per year. And radical cystectomy, which involves the surgical removal of the bladder and the bladder and prostate in men, is the gold standard for invasive bladder cancer. We are seeing an increasing number of patients with invasive and advanced disease. This is likely due to our aging population. Bladder cancer is a disease of aging individuals, with the average age being about 73 years. In addition, at academic medical centers, we're seeing, due to ad hoc regionalization of with an increasing number of invasive bladder cancer patients, partially due to the complexity of the care, as well as the reimbursement environment, and with data, which I'll touch on in a little bit, showing kind of high volume centers providing better outcomes. So I'm going to talk to you today about how do we improve the quality of care, some things that have already been done over the last 10 years or so, and then obstacles that need to be overcome and going forward. So the 90-day complication rate with radical cystectomy is 64 to 78%. So a very high complication rate. About half of these complications are within the 0 to 30-day range, and the other half in 30 to 90 days. A variety of different complications, including infectious and GI complications, primarily due to the urinary diversion, which incorporates the use of a small intestine as part of the diversion. You see readmission rates anywhere from 25 to 43%, and probably 42-43% in large SEER Medicare data being probably the most accurate. And 90-day mortality rate of upwards of 10%. So this is a challenge for us who take care of these patients, but I think also represents a significant opportunity for quality improvement, and we'll try to touch on some of that today. Some of the ways, I think, to improve outcomes, which I'll talk about first, include improving the use of multimodal therapy, and we'll touch on this. And then second, improving the perioperative outcomes and the perioperative journey for the patients undergoing radical cystectomy. So let's talk a little bit at first on multimodal therapy. So we know that cystectomy, it does provide the best treatment for patients with localized disease. And the cure rate, the 5-year disease-free survival rate for that, for localized disease in cystectomy, radical surgery, is about 50%. So, and it has been 50% for the past 20 or 25 years. We haven't moved the needle quite a bit on that. So the question exists, why is that? And it's likely due to micrometastatic disease that exists at the time of presumed localized disease. So the question arises, is it possible to improve outcomes with perioperative chemotherapy, as is done in other disease states? So when we talk about perioperative, we are referring to neoadjuvant or adjuvant therapy. So that's before or after radical cystectomy, and to be distinguished from chemotherapy, therapeutic chemotherapy, which is after the identification of radiographic metastatic disease. What is the rationale for early perioperative chemotherapy? Well, it's really the concept similar to breast cancer, lung cancer, and other colorectal cancer, is early treatment of micrometastatic disease. We know as an oncologic principle there's increased chemosensitivity when the tumor burden is smaller, and we can ascertain chemosensitivity. So perioperative chemotherapy refers to neoadjuvant before surgery, and the potential benefits here is the earliest treatment of occult metastases, trying to deal with those micrometastatic disease even before surgery. We know that early chemotherapy does result in pathologic response rates in a large number of patients. In fact, the P0 rate, so finding no residual tumor within the bladder in chemotherapy, after chemotherapy, is about 25 to 38%. That number is about 12% with no chemotherapy. So this does show that we do have a local response, and also are able to sometimes take unresectable patients, downstage them to resectable patients. And we do know, due to large, there's 11 randomized controlled trials and large meta-analyses that show there is a survival benefit to cisplatin-based neoadjuvant chemotherapy on the order of about 5%. So it's not the magic bullet, but it does provide some benefit for patients at 5 years. The neoadjuvant chemotherapy that are used are platinum-based regimens. Typically, MVAC and gemcitabine cisplatin have been shown to have that benefit. It's important to note that carboplatin is not an effective substitute for cisplatin. So when there are patients that are not candidates for cisplatin, we often see the substitution of carboplatin, but it's actually not an effective substitute and should not be done, because when we do employ neoadjuvant strategies, this does result in a delay, which is fine for the cisplatin regimens because the survival benefits are seen, but in carboplatin there aren't survival benefits, so this only results in delay and should not be done. The next part of perioperative chemotherapy is, what about the use adjuvantly after cystectomy? Benefits of this are still relatively early treatment of occult metastatic disease, not as early as neoadjuvant, but still relatively early. It allows you to apply chemotherapy based on pathologic stage, which may be more accurate than clinical stage, but is there a survival benefit with that? Deficits of adjuvant are it's difficult to assess response because you've already removed the primary treatment, and there does tend to be some enhanced toxicity, and trying to deliver chemotherapy after radical surgery is a challenge and does delay that systemic therapy. There have been a few randomized controlled trials. The data isn't as robust for adjuvant versus neoadjuvant, but some meta-analyses have shown some survival benefit, 9%. I don't think we can compare 9% to 5%, because again, the data here isn't as robust, but there does seem to be some benefit to this. So I think we are seeing, to conclude this concept, I just wanted to touch on this, of perioperative chemotherapy, increased uses of platinum-based chemotherapy. This was done about 12% of the time 15 years ago, 20 years ago, and now is more common about 30% of the time, according to the NCDB data. And the numbers, again, are improving. You see here 34% in a recent Bladder Cancer Advocacy Network survey. Some 12% is neoadjuvantly, 22% adjuvantly. Unfortunately, 35% are using non-cisplatin-based regimens, which is probably suboptimal. We'll tend to, at UNC, do the majority of this neoadjuvantly if we can. I say if we can because there are some limiting factors, including renal function and ototoxicity and neurotoxicity, or patients with underlying hearing loss that we might not employ neoadjuvant. In those cases, we'll try to do adjuvant. But it does highlight the need for us to look at less toxic regimens to employ perioperative chemotherapy. So the first poll everywhere question is, neoadjuvant chemotherapy for bladder cancer involves the use of carboplatin, reduction in complications, improvement in overall survival, no delay in surgery.
Thank you so much to those of you who've already answered. Just a reminder, these are all anonymous, so go ahead and take a chance on this,
Yeah.
and take just a few more seconds, if you would, to go ahead and respond to this.
There are no losses in this. Everybody wins a trophy.
How are they doing, Dr. Pruthi?
Good. We have a few choosing carboplatin, which, as I mentioned, is not an effective substitute for neoadjuvant chemotherapy. Yeah, now the numbers are going down with that, because remember, it doesn't have the same efficacy, and the negative of it is it results in delay. So it's not an effective agent in neoadjuvant. Neoadjuvant chemotherapy does improve overall survival. It does delay, but it does improve overall survival still.
Great. Thank you to everyone for participating. There'll be some more coming up.
So radical cystectomy. So we've talked about multimodal therapy. I want to talk about kind of to date, what are the improvements? And these involve clinical care pathways, robotics, and then I'll talk a little bit about obstacles to optimal care. So when we think about innovation, I think we often think about innovation as the new targeted therapy for cancer. in the surgical world, it's product innovation, right? It's often focused on product, in that case, robotics, and we're going to talk about that. But I think an important area that is needed as far as innovation of perioperative care is the process innovation. How can we improve the surgical experience and journey for patients? And this has been, I think, classically in our world, in the surgical world especially, somewhat limited. It's tough to innovate in what we don't know and what we don't see. In that, we've tended to do things and see things in the way we've always done it, the way we were taught by our mentors, and do it that way. I think this is an opportunity, process innovation, and rethinking how do we deliver surgical care. And I'm going to take, in the concept that Emerson refers to, something we often refer to as what's called functional fixedness. And functional fixedness refers to how we tend to see an issue. So I'm going to take just a few 30 seconds here to put forth what's called the candle, to illustrate what's called the candle problem by Dunker, to illustrate functional fixedness. So the question here for everybody to think about, kind of where you're at, is that he proposes: how do we attach the candle to the side wall, so here, and light the candle so that the wax doesn't drip on the floor here? And so take 20 seconds to think about that question. This is to illustrate sort of how do we think about things differently and what we faced in surgery. So how do you fix the candle, attach the candle to the side wall and light it so that it doesn't, the wax doesn't drip on the table itself? Give you a few seconds here to think about that. So the solution is shown here, that we use the box and attach that to the side wall and put the candle within it. And this is what we were shown over here. But if I were to have shown you this bottom instead, we think about things very differently, because now we don't think about the box as something to hold the tacks in, but we think about the box as maybe in a different use, a different way of looking at what we have and the problem we have as far as the solution. And I think this is important, and functional fixedness has been shown to be, the older we get, the more functional fixedness we have. So I think, to me, this is an incredible opportunity for younger individuals to innovate in the world of surgery, of how do we think about the surgical journey and process innovation in a different way. And the guru of overcoming functional fixedness has been MacGyver, who could overcome anything he faced, right, with just doing things a little differently. So that's, I think, what's important. And when we think about process innovation, and we're going to talk about things, is how do we look at the world a little bit differently. And I'm going to first talk a little bit about care pathways. So care pathways are, how do we deliver, looking at things like the Toyota production system, how do we apply kind of a systematic way of approaching surgical delivery? The potential of surgical clinical pathways are a variety of things I'll talk on: cost reduction, staff satisfaction, but involves standardization of the approaches to delivery of surgery. So one of the benefits is cost reduction. Often is the most important for healthcare decision makers, and much of the research and care pathways is focused on this. Care pathways, sometimes there's a lot of different terms. Today we refer to it as ERAS, or Enhanced Recovery After Surgery. But cost reductions have been seen in a variety of surgeries, including urologic surgery, and I'll touch on our experience with this. This is primarily due to reduction in length of stay and OR times. What they allow for is parallelization of processes, so we're not doing things sequentially, but in parallel more efficiently, reduction of unnecessary diagnostic tests, a better utilization, efficiency, and use of surgical equipment and meds, and avoid duplication of services. Pathways have also been shown to improve the quality of care, reducing the morbidity of the care that we deliver and overall complications, and in turn, reduction in mortality of care. I think one of the benefits of pathways are transparency of treatment, allow for some level of structure and organization of the care that we're delivered in a stepwise, well-defined continuum that's available to all, documented, evidence-based, and available and seen by physicians, the staff, and even the patients. So everybody understands what is on post-operative day 2, what is expected from the patients, the staff, and the caregivers. It isn't a opaque process that's kind of determined by the attending physician walking in the room that morning, but a very clear stepwise continuum. It leads to improved education and a structured evidence-based approach, a move away from the guild system that all of us have often been accustomed to, that we learned this from our mentors, they've done it this way, so we're going to do it this way, and they learn from their mentors and so forth, but is a mode of translating scientific evidence, evidence-based practices into clinical practice in a multidisciplinary setting. This has been shown to significantly increase staff satisfaction as well as improving quality of care increases staff satisfaction, because everybody understands and known what is to be done next. So which cases make the most sense for care pathways? High volume cases, if you're doing one of these every 6 months, there's not much of sense. Those that are relatively complex, that have a lot of moving parts to them, a hernia surgery, a straightforward hernia surgery might be high volume, but probably there's not a lot of variation, there's not a lot of resources used. So ones with high resources, a lot of variation, and high morbidity, so there's a lot of opportunity to move the needle. And radical cystectomy, which we're going to talk about today, hits the mark for all of these aspects and is ideal for care pathways. And I'm going to talk to you a little bit about the care pathways that we use here at the University of North Carolina. And we first reported these now 15 years ago, and at the time we called this a fast-track surgery or care pathway. And again, as I mentioned, now it's a very common topic. I think in the last year and a half, if you do a PubMed search, there'll be 20 articles on ERAS in cystectomy. So it's come a long ways from some of our first descriptions of this, but the concepts are similar no matter what you call them. And it begins before the surgical journey in the preoperative counseling. And I think this is probably one of the most important steps, informing patients about the pathway, the steps. We use preoperative literature of what is expected from the patients and their family before surgery, day 1, 2, 3, 4, 5, and even after. Even expectations on length of stay. Our patients tend to stay 4 or 5 days. If you tell them it'll be a week or 2 weeks, then they plan on that. And I think just setting up the expectations is one of the first and most important aspects to pathways. Some general concepts, and I'll show this in a little bit more detail. I'll show you what our pathways are and touch on a few highlights. Significant change in how we use antibiotics, and this has a lot of benefits in addition to issues of resistance and C. diff infections. Cardiovascular management of these patients. This is always a little bit of a moving target, but encourage people, and whatever your pathway is, to develop institutional policies consistent with your cardiologist and your anesthesiologist. Vte prophylaxis is important. These are major surgeries, and developing ours are fairly aggressive VTE prophylaxis. Pulmonary rehabilitation, we use incentive spirometry. To be honest, there's not a lot of strong data on its use, but it tends to be inexpensive and something relatively easy. And what is very important, has been important in this, is the use of multimodal non-narcotic analgesics. This has been important especially in the current environment where we're paying more attention to minimizing opioid use. And we've used our pathway to really make a difference in that regard as well. To touch on a few things, we used to prep these patients with kind of like a colonoscopy type of prep. We no longer do any prep anymore. This has really been a significant change. Benefits of this: patients don't need to be admitted. They stay hydrated because they don't go through a significant preparation and come in much more hydrated as well. I've talked a little bit about the antibiotic use. The patients get basically 24 hours and one dose of antibiotics, a 24-hour antibiotic starting right before incision. We use non-narcotic analgesics, including Lyrica. We use alvemopan, which is a mu opioid receptor antagonist, which has been shown to decrease the ileus. So when people take their opioids, it decreases the effects on the bowel. And aggressive Vte prophylaxis beginning preoperatively. A few things here. Again, you see a lot of the things I'm going to highlight here is we don't use NG tubes anymore, and you see what's highlighted, a lot of non-narcotic analgesics, minimizing the use of morphine and the consequences they can have as far as delay of bowel function and even post-operatively. It's going to, again, touch on some of this you'll be able to see later as far as the pathway. Use of chewing gum, which has been shown to stimulate gastric and orogastric reflexes and the return of bowel function. One thing we do is more aggressive return of feeding for patients, irrespective of bowel function, clear liquid diets beginning on day 1, and beginning discharge planning right away, converting to oral meds on day 2, and again, this kind of continued bowel feeding. And then a regular diet on day 3, and starting with discharge planning for beginning on day 4, and starting to talk about discharge on day 4 and coordinating that discharge. And with discharge, typically on day 4, you see here again the focus on these non-narcotic analgesics, including COX-2 inhibitors and Lyrica at home, to minimize the potential use of pain medicines. We've actually used this pathway to better understand how much narcotics are needed. Typically, we would send people home at 30 or 40, and we found when we looked at it through the pathway that the median use was 10, plus or minus 4. So with the use of non-narcotic analgesics, so now we send patients home with 15, which covers most people. If patients, the people who will need more than that tend to be people who had higher narcotic use before surgery, or higher inpatient narcotic use. And we send patients home on Vte prophylaxis for the next 30 days. And you see here our experience going back 20 years before, and then this category is with employment of the pathway, reduction in ICU stay, time to discharge, and translating into cost as well. So there are benefits to that. So summary points, I think it's had a positive effect on quality, education, staff satisfaction, and our ability to take scientific evidence into clinical practice. So a poll everywhere question for you. Clinical pathways in cystectomy have been shown to do all except reduce length of stay, reduce complication, reduce quality of care, and reduce costs. So initial answers are reduce quality of care. So correct, it has been shown to reduce length of stay, complication, and cost, and has not been reduced the quality of care. In fact, it's improved the quality of care. So that's correct as C. So I'll move on, and I'm going to zip through this aspect of role of robotics in minimally invasive surgery. Robotics approaches to cystectomy has emerged from our experience with radical prostatectomy for prostate cancer. Minimally invasive surgery, laparoscopic approaches has been shown to benefit gallbladder surgery originally, kidney surgery, and in bladder cancer you can see typical cystectomy is a large midline incision, and now with robotic approaches, small incision or no incision, we'll talk about that. The benefits which we've seen have included reduced pain, reduced blood loss, and fluid imbalances because we're doing everything in the intra-abdominal environment. And originally the concerns were the OR times and will it compromise what we do oncologically. We probably had some of the most important, to take a little sidetrack here, our contributions to robotic approaches to bladder cancer have ranged from application to females, cost analysis, and to is this truly the right way to do it? And I want to show you that in analyzing it, these are things that have been shown in our experience and others to be comparable, beneficial to robotics, and negatives. And just bear with me here. I think whenever you have a new surgical approach, it's important to think, is this a surgical stunt or does this provide value to our patient? And using the Michael Porter's definition of value, where outcomes value is increased if your outcomes can be better than your costs. So outcomes are beneficial with robotics with regard to less blood loss, less transfusions, less pain, reduction in length of stay, and reduction in complications. So that is the benefit. What is the cost? It primarily has been a little bit longer OR time, about 45 minutes longer, which is a cost to the patient and maybe a financial cost. Although when we've done financial cost analysis, these are aspects that are no different between the two. So I think from a patient standpoint, a little bit longer under anesthesia for benefits of less complications and less pain and blood transfusions has translated into increased value for the patient. So I think robotic approaches to cystectomy does add value to the care of patients undergoing radical cystectomy. Where are we going with regard to robotics? I think we're seeing an increased worldwide experience. We're seeing the long-term, the 10-year now oncologic assessment and large multi-institutional randomized trial has recently been completed, which we were part of, that was published in Lancet, showing those benefits, which I've touched on, and starting to do the intracorporeal diversion, the diversion within the abdomen of a patient. And I'll show you very quickly a little bit of the robotic approach, just so you can see as I talk a little bit about it, that we can now do the bowel diversion, the ileal conduit or the neobladder within the abdomen robotically. And we have the technology now, the staplers, to be able to do this. You see these arms here are moving, are the robotic arms, to allow us to do the surgery again within the abdomen, so we no longer have to make an open incision for this. The scissors here are from the bedside assistant, and the other instruments are by the robotic approach. To show you this for another minute, but you can see now we can do the surgery with the room in an insufflated abdomen, can do even the urinary diversion part robotically. This is us doing the bowel anastomosis. I'll show you this for a little bit longer. This was stuff that we had never thought before we could do without our hands being in there. But you can see with the way the robotic arms move, it's highly articulated, and the surgeon sits actually at a console that's away from the patient and controls robotic arms. And here you see the ability to, now we're connecting the ureter to the urinary diversion, and we can actually sew, do some fine sewing movements robotically. I won't take you through all of this, but again, you can get a sense here of what our ability to do it. Now, when we did the diversions robotically, some benefits we've seen, or it took us a little bit longer, but did result in less inpatient narcotic use. And so this is a patient that now has basically no incision. Remember that first incision, which was from the xiphoid to the pubis. One question was, how do we remove that? And we removed it through the ostomy site or through the port. But here's a patient, again, who has had a cystectomy and no incisions. And the way we removed the specimen here was, there's a female patient. We made a small incision in the vagina, was able to extract the specimen and then sew up the vagina. So this is sort of the next technology of how we're doing it. So we've talked about improvements in pathways and even technological improvements in robotics. Now I want to switch gears a little bit and talk about what are some of the obstacles to optimal care. And some of this, again, goes back to that idea of functional fixedness, is identifying how do we think differently about what these obstacles are. Some of the obstacles we've identified, I'm going to talk briefly about in the next 20 minutes, is travel distance, financial toxicity, and nutrition. So talk a little bit about travel distance. So there has been a national trend towards regionalization of healthcare for major surgeries, cardiac surgery, Whipple operations, and radical cystectomy, going back to John Berkmeyer's paper from 2000 in the New England Journal of Medicine that shows improved, and other studies have shown improved postoperative outcomes, perioperative postoperative outcomes when surgery is done at high volume centers. So this might be true, but it does beg the question, there's not high volume centers around the corner for everybody. This involves patient travel to these centers. And I've talked about this already. The complication with radical cystectomy is very high, and readmission rates are very high also. And this is work done by Karen Stitzenberg, the surgical oncology group at our institution, as well as the urology group, where she showed that actually radical cystectomy in the blue line here actually has the highest 30 and 90-day readmission rate, up to 43%, higher than even pancreatic surgery, esophageal, and lung surgery. And that many of these readmissions occur in the first 30 days, but about half of these in cystectomy will occur from 30 to 90 days. She's also shown here, and I want to show you to this graph here in the upper left side, shows the blue line is survival. This relates to survival. The blue line is no admission. The yellow line is 30 days, were readmitted at 30 days, and gray line is admitted 30 to 90 days. So worse survival occurs for those patients who are readmitted in bladder cancer surgery. So high readmission rates, if you do get readmitted, it does have a negative impact on your survival. So 30% of bladder cancer, this is other work done by that group, Karen Stitzenberg and Angie Smith and Matt Nielsen, our group, looking at 30% of bladder cancer readmissions tend to be to a different hospital. So if they are readmitted, a significant proportion tend to be to a different hospital, and only 8% of those are transferred back to the index hospital. This early study, I'll show you more on this, that if you are readmitted, they tend to have worse survival. And this does beg the question, does travel distance play a role in this issue of readmissions, risk of readmission, and complications? Because we do know that this does have an impact on outcomes. So we looked at that question and looked at linked data in the North Carolina Cancer Registry, included patients who were diagnosed with that, and looked at travel distance from the straight line, so as the crow flies from the zip code to the index hospital where the cystectomy occurred. This showed that 44 patients were readmitted, so that's about in line with what we've talked about before. Half of these were admitted within 30 days, half 30 to 90, again, consistent with the SEER Medicare data nationally. Age was a little older in those readmitted, not significant, but otherwise, those who readmitted and who weren't readmitted, no other difference in the patients as we could identify, except with regard to, if you look at here, readmitted, if you lived less than 30 miles, your readmission rates were significantly lower than if you lived longer than 30 miles. And 30 miles is often used in medical literature as the difference between excessive travel distance. So it doesn't have to be 100 or 150 miles, it's 30 miles. And you see already at 30 miles, significant readmission rate differences in those who live longer than 30 miles. And even this is for the less than 30-day admissions and 30 to 90-day. Again, live longer than 30 miles, significant increase in readmissions. And even on multivariable analysis, distance between the index hospital and where being longer than 30 miles was an independent predictor of readmission. So travel distance does impact readmission significantly. Also in the study, we showed significant differences in survival if you were readmitted in general, the survival was worse, and if you were readmitted to a different hospital, the survival was even worse than that. So again, what we're seeing is longer travel distance to a cystectomy provider is associated with higher readmission to a different hospital, and worse survival. So we may espouse the benefits of high volume centers and the better perioperative outcomes, but are we undermining this benefit with issues related to travel distance that the patients have? So it begs the questions that needs to be explored further, probably beyond cystectomy. Do those patients, could they benefit from shorter or more frequent follow-up by phone, virtual postoperative checks, telemedicine, or maybe better care coordination with the primary care physicians? I think this is going to be significant, looking just beyond, hey, high volume centers are the place to get these the benefits of high volume care, but we can't undermine that care. We need to figure out how to do this in a better way. I think also the future directions is better understanding why healthcare disparities exist between these early versus late complications and between the care versus outside versus index hospitals, which should be transferred. But again, a new question is, how do we identify this new obstacle of travel distance? I want to touch a little bit now on financial toxicity, which has become a common discussion of care, medical care in general, and especially of cancer care. Financial toxicity is defined as an adverse financial condition as a consequence of medical treatment. You may have heard this, that cancer patients are almost 3 times more likely to declare bankruptcy than those without cancer. So it does have an impact. 13% of non-elderly patients with cancer spend at least 20% of their income on treatment. And even those with Medicare spend significantly higher out-of-pocket expenses than those without cancer. Of the 20 million cancer survivors, 29% reported financial burden of some kind. So this doesn't even have to include bankruptcy, but some level of financial burden. 86% of those with financial toxicity did have health insurance. So even those who are insured are impacted. So I think the question undoubtedly is, development of a cancer diagnosis will lead to financial toxicity or financial burden. But the next question is, does it affect the medical consequences, including survival? It's been shown that a copay of $50 a month, just to give you a couple examples, kept nearly a fifth of patients from continuing to fill their prescriptions for targeted therapy, TKI therapy for CML, very effective therapy for CML. $50 copay reduces the adherence by a fifth. And increasing copays, out-of-pocket expenses by $10, each $10 decreases oral TKI therapy by 13 to 20%. So what we're seeing here in different cancers is that even what I would feel would be relatively modest amounts of out-of-pocket expenses do decrease adherence to therapy. Half of the people, insured cancer patients, do report decreasing cutting spending into a variety of their activities, including leisure activities. And some of these are receiving financial assistance. So we are seeing health consequences of cancer patients and financial toxicity on outcomes. First study showed more likely to die from all causes. This was in the SEER data from the Seattle area, highest for colorectal and prostate cancer, more like in those who are younger, female, non-white, and with a more advanced disease, as one might expect. Lower rates of survival for those patients who have financial toxicity. We know that urologic cancers tend to be expensive with regard to their long-term surveillance and the treatments. I mentioned this before. Bladder cancer has the highest per patient treatment cost of any cancer. So it's a very expensive cancer from diagnosis to death. So we sought to evaluate that using the UNC Health Cancer Survivorship and just ask that question, is financial toxicity an issue, with follow-up, and did some quality of life surveys as well. Just very quickly show you that in our study with bladder cancer, about a quarter of the patients did report to have financial toxicity. And these tended to be younger, African American, and again, I'll summarize this in a moment, lower education and non-invasive, and did have an impact on quality of life. So I'll just show the summary of what I just showed you. A quarter have financial toxicity. They tend to be younger, more likely to experience younger patients, and probably related to Medicare eligibility. An increased prevalence in African Americans, those with less education, and those with non-invasive disease. So this may be due to the frequency of follow-up and length of surveillance of these patients, which have expensive surveillance protocols. And this did correlate with worse quality of life from physical, functional, and mental health regulated quality of life that we showed. So the next questions that arise is what we've seen in some other cancers is, does this affect healthcare adherence and then thereby affect mortality? And better characterizing financial toxicities, how does this develop? And what strategies can be put in place to help mitigate the effect of financial toxicity? One might be in the role of maybe our surveillance strategies are too intensive, to be honest, that are there ways for certain subgroups of lower risk patients that we can reduce that and perhaps reduce financial toxicity? And last I want to touch on in the last 5 minutes is something just to touch on this aspect of nutrition And what is the role of nutrition? Nutritional deficiency is defined as follows: inadequate nutrients in the tissues due to inadequate dietary intake, digestion, absorption, transport, or metabolism. We know elderly individuals are at increased risk for nutritional deficiency. It's important to remember that, I mentioned this before, the average age of the bladder cancer patient is 73 years. 40 to 80% of cancer patients are deemed nutritionally deficient. So the elderly cancer patients, which is the bladder cancer patient, is at particularly high risk. So I'll give you an anecdotal case, which is a not uncommon case of a patient we see. 70-year-old man presents with invasive bladder cancer, complains of having a bad taste in his mouth, some weight loss before surgery, which is a radical cystectomy. His postoperative course is complicated by wound problems, readmission, TPN, and prolonged length of stay. I mentioned the high rates of complications with cystectomy. And it begs the questions, are there things, is this inevitable, or could this be prevented with preoperative evaluation and nutritional intervention? We know that nutritional deficiency is a well-known risk factor in surgery, resulting in wound infections, poor wound healing, and mortality and survival effects. There is a correlation between malnutrition and high clinical economic effect, length of stay, costs of healthcare, and, as I mentioned, morbidity and mortality. I mentioned the role of urology is an exceptional, and not exceptional in a good way, position in the fact that the majority are over 70. And if you look at one of the nutritional deficiency questionnaires, the tool NRS 2002, patients who are over 20 having a major surgery have a score of 3 or higher, which is already at risk of nutritional malnutrition, independent of all other factors. If you add in malignancy, which these patients have, that is yet another factor. And even back 30 years ago, a study at UAB, a small study, showed, looking at albumin and white blood cell count as markers of nutrition, 75% of those with nutritional depletion had severe complications. So the first signals of this began 30 years ago, and more recently, the group at Vanderbilt showed about 20% of their patients were nutritionally deficient. The 90-day mortality in those nutritionally deficient was over 3 times higher than those who were non-nutritionally deficient. And even survival at 3 years, significantly worse for those nutritionally deficient. Our group, by Johnson and Smith, looked at NISQIP data, showed low albumin, the strongest predictor of complications, and Angie Smith's work looked at sarcopenia, a major predictor of complication, trends towards impact on survival. So the data is out there of the impact of malnutrition in bladder cancer patients. The assessment of nutritional status is not an easy one. It's not straightforward. There's not standardized definitions, a variety of different traditional markers to that, and indices. Ideally, the best marker would be that which incorporates multiple factors: the patient's physiological requirements, the intake, body composition, and the ideal marker should be that sensitive enough to detect it at early stages, sensitive enough to be potentially only due to nutritional imbalance and not a covariate with disease state or cancer state, and one in which intervention would correct this alteration. Albumin has often been used, even dating back 30 years. Unfortunately, low albumin counts can be due to other aspects, including on top of malnutrition, but it could be due to disease state as well, but is often what is used. In the absence of a gold standard, I think many people have looked at nutritional indices. There's a variety of them. At UNC, we've tended to use this last one, which tends to be fairly complex and comprehensive. This is one of the fairly easy tools that can be used in a primary care community urologist office. This is the PGSGA that is very comprehensive, as you can see here, and this is employed by our nutritionists here at UNC. So we, to be fair, don't, as urologists, employ this, but we bring in our registered dietitians early in the process who evaluate the patients on a more complex level. I think, though, getting the patients and the referring physicians involved early, maybe with some of those more simpler tools, maybe plays some of the most important role, because this is the largest window between diagnosis and surgical therapy where we can perhaps optimize the patients with nutritional supplementation, dietary aspects, we get our dietitian and nutritionist involved very early. And I want to take a moment here to look beyond dietary, the early interventions with things like smoking cessation, weight loss in some patients, and the concept of Prefab, building patients up. I mentioned neoadjuvant chemotherapy in the 3-month window. Are there things that we could do in that window to build patients up? We do rehab on the back end, but on the front end to build them up. To just take you very quickly through this, this is our protocol. When a patient's come to us, initial consultation, most patients get neoadjuvant chemotherapy. We try to have them seen by an RD in an adjoining clinic and have them evaluated. And in visit 1, and again, this is where they get some preoperative diet optimization and just show you some of the regimens and evaluations that are shown here. But again, getting a registered dietitian involved early. The next visit is right after their surgery in the hospital to reiterate the home recommendations and get them involved. The next visit is 2 to 3 weeks after surgery, review the recommendations and what improvements may be seen. And often we do undertake this 4th visit at 3 months to repeat the assessment and further recommendations as needed. So again, our system has involved the registered dietitians involved early, and this has been key for us. So our last poll everywhere question as we finish up here: which of the following is not an obstacle to the care of some cystectomy patients? So which is not an obstacle? Distance, cost, access to robotics, nutritional optimization. So wonderful. So people have hit on it. It's not access to robots is the problem. It is issues of distance, cost, and nutritional observation. So in conclusion, malnutrition is an important risk factor. I think better assessment early on, better studies are needed to identify how to intervene early with diet, exercise, and other health-related behaviors. So I've talked a little bit about this already and the importance of improving outcomes. I'll touch on this in a moment. One quick comment, 2-minute comment on what we're doing in mHealth, and Angie Smith is doing a lot of work in this area in trying to address this is how do we, with patient-reported outcomes, as we understand more from the patients. I talked about the pathways until discharge, but I think the pathway really probably extends out to 90 days. And this begun with structured phone calls by our APPs in understanding what's happening at home and improving the communication. And we've taken this to the next step of using health information technology and a mobile health devices and iPads in a very structured way where patients very easily, even older patients, can track symptoms and they're reported back to us. And it gives them some real-time feedback to drink more fluids or other aspects or how to better handle their ostomy care. Or if there's enough symptoms that concerns, it kicks it back to us, to our nurses, to call them at home and to intervene in a timely way to avoid the trip to the ER and for dehydration or fevers and for readmission. What we've noticed is high patient, in addition to reducing morbidity and utilization, very high patient satisfaction. As often these patients, they don't feel stranded at home after these very complicated surgeries. And I think this is truly the essence of patient-centered care and the utilization of health information technology. So again, as we see an older population and more bladder cancer complex patients, I think we need to continue to think about how do we innovate for these patients, see kind of the unseen unmet needs for patients. And finishing with this quote by Peter Pronovost, who's sort of the father of the checklist, is I think we need to begin to look at the delivery of care more as a science, and it's efforts we're trying to do here at UNC. And I'm happy now to answer, as we have Spring and Chapel Hill, any questions anybody might have.
Dr. Pruthi, thank you so much. This has been fascinating. You can go ahead and submit those questions now. Just quickly want to thank, let's see, I'm going to jump over to our question area here, and if you have not already submitted via poll everywhere, you can go ahead and submit questions now. Just if you're doing that by phone, type in your question, or you can put the question in the question field there on poll everywhere. So Talking about the preoperative counseling, how much of this is going on currently in terms of as patients are first meeting and being counseled in terms of the financial toxicity discussions, in terms of the thinking ahead about this whole issue of travel and distance and getting to that center that would be optimal for their postoperative care?
Yeah, so we're engaging in that more, and we're actually utilizing our APPs more as that consistent person, and our nurse navigators to help navigate the patients through that process with it, because it can be daunting for a patient to come in and hear so much information at once that we give them contact information that we can reiterate these messages over and over again.
Yeah.
I think the mobile health technology has really been very useful, because that can be employed when the patient is 200 miles away in Asheville, North Carolina, or further, with that, and they can feel connected in.
Yeah.
And in fact, we have ways of even kind of Skyping with them to be able to talk to them, and they can show us their wound and how does it look if they have questions. So they don't need to travel that distance, where we can be connected and coordinate the care a little bit better. And that's been, I think there's such tremendous potential in that to overcome issues of travel distance, overcome longer term complications, and some of these issues. The financial toxicity is perhaps one of the greatest challenges, but I think it starts with some level of awareness that this is happening.
Right. Are there ways with counseling to prepare people so that they can begin to look at resources that may be available to help combat financial toxicity prior to?
Yeah, I think early involvement of financial counselors in that, and I think admittedly us sometimes as providers have never thought of that is a component of their care and may affect adherence of the care. So I think for us as providers, not thinking of in isolation that we have a new therapy or surveillance for patients without thinking of those other consequences. So we get the financial counselors involved early.
This is part of the science. This is part of improving the outcomes.
Yeah. So, I have the opportunity to actually for non-bladder cancer invasive guidelines to sit on our national guidelines.
Okay.
And we came out with new guidelines last year, and in fact, we altered some of our post-operative surveillance strategies with this in mind of not doing as intensive follow-up for patients who may not need it.
Gotcha.
With the idea of the financial impact.
That it's more tailored.
Yeah.
Okay. And we do have a question. Can you speak more to your Pre-Fab program?
So our Pre-Fab program has typically been admittedly more involved the issues of smoking cessation and the nutritional enhancement to it. We haven't done as much and involved as much with our physical therapists and occupational therapists. We've spoken as a group about, is there a role of getting all kind of elder, because I think this is applicable to all older oncology patients, almost a preoperative clinic for them to be seen at where this can be done. So to answer your question, admittedly, we haven't brought in the physical therapists and occupational therapists in that regard, only when it's been more extreme. I think it would benefit even that more active patient. We've only addressed it from the standpoint of nutrition and smoking cessation, which we've gotten involved early. But I think that's probably the next component is the physical prehab into that.
And I wondered, how do you balance the immediacy of wanting to remove the cancer against the potential benefits of those prehab strategies?
Yeah, that's a great question. Now, in the bladder cancer patient where we talk about the benefits of neoadjuvant chemotherapy, to me, that represents a 3 or 4 month window opportunity while they're getting chemotherapy where they could be getting prehab and intervention. Because sadly, what we're doing in that time is actually beating them down a little bit more rather than utilizing that time as an opportunity going into surgery.
And something like cisplatin can be pretty brutal, so that's got to balance against trying to get them more physically active at the same time. So, okay. Yeah. Fascinating. Well, thank you so much. We should wrap up. Let me jump back to one slide. We want to thank the generous support of the North Carolina General Assembly for the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, and John Powell for all the hard work they do to make this and every lecture possible. Upcoming, we've got RN and Allied Health lecture on May 8th prostate cancer screening, and then medical and surgical oncology lecture May 22nd, the role and importance of HPV infection in head and neck cancer. We hope you'll join us for both of those. We've also got new courses online on that's at learn.unccn.org, and you can now take the cancer-related cognitive impairment, more than just a side effect of chemotherapy, and key 2018-19 developments in lymphoma and thrombosis anticoagulation. So both of those are available as well. Thank you so much for being here. If you have questions or comments, please reach out to us, 919-445-1000. Find out about becoming a promoter, or just spread the word about these lectures. Watch old ones, check out the ones that are coming up. We hope to hear from you soon. Have a great few weeks, and we'll look forward to seeing you for our next lecture. Thanks so much. Thank you so much, Dr. Pruthi.
Yeah, thank you very much.